Today we are going to be covering neuromuscular disorders and cranial nerve disorders. Neuromuscular disorders involve a disruption of impulse transmissions between neurons and the muscles they stimulate. First, we're going to talk about Guillain-Barré syndrome. Pathophysiology, this is an autoimmune disorder that attacks the peripheral nervous system, or the peripheral nerve myelin. This is segmental rapid demyelination in ascending pattern. Ascending means that it starts at the feet and goes up the body. So this starts in an ascending pattern. This causes lymphocyte infiltration, and there is a descending remyelination. So descending would be the opposite. So it starts from the head and it goes down the body. So with this, the disease is going to start at the feet, go up the body, and then as they recover, it's going to go the reverse order. It'll heal from the top back down to the feet. Schwann cell, remember we talked about in day one, Schwann cells produce myelin. So if there is no damage to the actual Schwann cell, remyelination can occur. And remember, myelin covers the nerve, insulating and speeding the conduction of impulses from the cell body to the dendrites. If you look back on day one, we've talked about that. This affects 1 to 2 in 100,000, usually between the age of 30 and 50. This is more common in men. With this, the peripheral nerve myelin can't send brain signals to the body, and the body can't send signals. So what's happening here there is a lack of communication because there is a lack of the myelin. Remember on day one we talked about this kind of being the insulation of a cord. So we think about if we have damaged the outside of our cord, our phone doesn't charge as well because we are losing some of those signals. That's kind of what's happening here with Guillain-Barré. There are different signs and symptoms are going to depend on the stage. There are 3 said stages. Stage 1 is 24 hours to 3 weeks. There's an abrupt onset of weakness and paralysis, may affect the respiration, and the ANS is affected. So that is your autonomic nervous system. So think of the heart. So blood pressure can be easily altered, cardiac dysrhythmias, bladder retention. In stage 2, which could be between 2 to 14 days, there's a plateau. So the progression of the disease has stopped. And then stage 3 is 3 to 24 months, and this is the recovery stage. In this, they may not be able to talk, laugh, cry. However, their cognition is completely intact. Some different diagnoses could be lumbar puncture with cerebrospinal fluid analysis. Cerebrospinal fluid will show an increased protein with normal cell counts. The nerve velocity test evaluates nerve functioning, and your pulmonary function test, or PFT, helps determine any kind of respiratory issues. Here are some common complications with Guillain-Barré: respiratory failure, autonomic dysfunctions, depression, pneumonia, a UTI, and complications of immobility such as pressure ulcers. So with this, you got to think that it is descending paralysis or weakness. So that means they're unable to possibly move, which if it goes up high enough to the respiratory system, that means they're not going to have respiratory functions. And obviously, complications of immobility, we want to make sure we're not causing any kind of pressure ulcers, so we're going to rotate them every 2 hours, checking the skin, possibly inserting a catheter so that they don't have that skin breakdown. Some therapeutic interventions would be the plasmapheresis. Plasmapheresis is when the liquid portion of your blood is removed and separated from your blood cells. Then your blood cells and new plasma are put back in. The purpose of this is to decrease the circulating antibody levels and to reduce the amount of time the patient is immobilized and dependent on the mechanical ventilation. We can also give IVIG, which are antibodies. These can help by stopping harmful antibodies. We're also going to give oxygen, mechanical ventilation, emotional support, and make sure that they have the rehabilitation that they need. Nursing care. So what do we look for? What do we do during this situation? We're going to monitor their vital signs. We're going to watch for any autonomic dysfunctions. We want to maintain respiratory function. With the respiratory, we can use incentive spirometry. We can monitor the vital capacity and negative inspiratory force with PFTs, which helps determine if mechanical ventilation is needed. And we also want to make sure we're monitoring any swallowing issues. Mobility, we can provide passive range of motion, position changes, anti-embolism stockings, anticoagulants, and we're going to turn the patient every 2 hours. Nutrition, they may need TPN. If unavailable to swallow, may need an NG tube. We need to make sure that we have bowel sounds and a gag reflex before we resume any oral food. Communication, we can try picture cards or eye blinking. Speech therapy will help pick what's best for the patient. We're also going to help with fear and anxiety, referral to support groups for families, encourage visitors, music, reading to the patient, let family help with care when appropriate. Next, we're going to talk about multiple sclerosis. This is a progressive degeneration of myelin sheath in the central nervous system. Onset is usually young adulthood and early middle age. Incidence is greater between the ages of 20 and 40 years of age. It's more common in women. The slowed or blocked nerve impulses enables nerve impulses to pass along the nerve fibers. Remember, in the central nervous system, these cells are not able to regenerate, resulting in permanent and irreversible damage. Here is what a affected nerve looks like with multiple sclerosis. Remember, the myelin is responsible for that smooth transmission of nerve impulses, and it protects the axon. We can look back on day 1 to talk about and review the difference between sensory neurons, motor neurons, and interneurons. Multiple sclerosis symptoms aren't easily identified. They're usually unique to each person. They're unpredictable and often invisible to others. We're talking about vision. The optic nerves refers to the inflammation and demyelination along the optic nerve. Fatigue, cognitive decline, spasticity, numbness and tingling, and bladder issues. Nerves in the bladder constantly tell the spinal cord and the brain how full it is. For a small amount of fluid, the central nervous system suppresses the urge to go. Once it's full, the signal is sent to the bladder muscle to contract, and to open the sphincter, allowing urine to empty. An overactive bladder is when fluid enters the bladder. You have a strong urge to go because the impulses are no longer suppressed. An underactive bladder, even though the bladder is full, demyelination in the brain and spinal cord prevents the nerve signal from reaching the bladder. So this can cause an underactive bladder, which could cause your bladder distension. With multiple sclerosis, they can have remissions and exacerbations. The big thing is with each exacerbation, the symptoms become more severe and last longer. Death usually occurs from respiratory infections. Some different diagnostics would be a history and physical. You can also do a lumbar puncture with cerebral spinal analysis. The cerebral spinal fluid may show an increase in the immunoglobulin G. The MRI could show plaques, as you can see in the picture of the MRI. Here are some different therapeutic interventions. Steroids could decrease the swelling. Interferon is an anti-inflammatory as well. Anticonvulsants can help relieve neuropathic pain. Immunosuppressants, so the body will not attack itself. Purpose is we want to remove plasma from the blood, which removes the antibodies that they are attacking. That's the purpose of your plasmapheresis, which we've talked about earlier. Next, we're going to talk about myasthenia gravis, which is grave muscle weakness. This is usually linked to the thymus gland. This is antibodies destroy acetylcholine receptors. Acetylcholine is unable to stimulate muscle contraction, which results in the loss of voluntary muscle strength. Fewer receptors are available for stimulation, resulting in voluntary muscle weakness. The etiology is unknown. Normally, neurons release a chemical neurotransmitter, acetylcholine. The acetylcholine receptors on the muscle tissue take up the acetylcholine, resulting in muscle contraction. With myasthenia gravis, the body's immune system is activated and antibodies attack and destroy the acetylcholine receptors. Therefore, acetylcholine receptors can't stimulate muscle contraction. If acetylcholine is not used, it will break down, not used as quickly in myasthenia gravis because there are less receptors. So we have less acetylcholine being used in the body. So if you go back to day one and figure out what acetylcholine is utilized for, you could be able to identify most of these signs and symptoms. The first one is progressive muscle weakness, fatigue with activity, drooping of the eyelid, diplopia, voice weakness, mask-like facial expressions. This results in progressive muscle weakness during activity, and it can improve with rest. Some different diagnostics could be a history and physical. Another one is a Tinslon test, which is when a fast-acting acetylcholinesterase inhibitor is administered IV. If symptoms resolve within 30 seconds of injection for 5 minutes or less, it is considered a positive test, which confirms the diagnosis. They can also do an anti-cholinesterase receptor antibodies, which is a blood draw. Some different complications would be aspiration, respiratory infection and failure, myasthenic crisis, and cholinergic crisis. So the myasthenic crisis is when there's not enough medication, and the cholinergic crisis is when there's too much medication. I have posted a Word document that describes the two differences, and I also posted a really great video that tells the difference between the two. Here is the video that I have posted for you to watch in Blackboard. There is no cure for myasthenia gravis. They could do a thymectomy, which helps because there will be no more antibodies are made. This could take 3 months to a year to notice any change. This is the removal of the thymus gland, and it helps because it decreases antibodies. Anticholinesterase agents destroy cholinesterase that breaks down acetylcholine. This helps because it gives acetylcholine more time to attach to the working receptors. Also could try steroids, immunosuppressants, and plasmapheresis. With myasthenia gravis, we want to make sure that we're teaching them medication compliance, teaching them ways to conserve energy, avoidance of infections, signs and symptoms of each crisis. We want to minimize aspiration. This means we want to make sure they rest before meals. Make sure we're setting them up right. They can have the neck flexed. Soft foods require less chewing. We also want to make sure we're providing eye care, so eye drops to moisten the eyes if needed. We want to provide any support groups for them as well. Amyotrophic lateral sclerosis, or ALS, is a motor neuron degenerate. So your motor neurons degenerate. Nerve impulse transmission is blocked, which leads to muscle weakness and atrophy. Etiology is unknown, but there is possibly a genetic predisposition. The average survival time is 3 to 5 years. So A, we break down the word. A means no, myo refers to muscle, and trophic means nourishment. So this means there is no muscle nourishment. Progressive degeneration condition, more and more muscles become involved, only affects the voluntary muscles, so the heart and GI are not affected, along with the ability to think and reason. Weakness and atrophy occur because they have no muscle stimulation. ALS kills the entire motor neuron. Some signs and symptoms would be progressive muscle weakness and atrophy, decreased coordination, muscle spasms, difficulty chewing and swallowing, emotional liability, speech difficulty, pulmonary compromise, and death due to pulmonary complications. Late in the disease, communications become limited to eye movement and blinking. No clinical lab test can be done to diagnose this. Diagnosis is made based on clinical symptoms. The other tests can be done just to rule out other issues. The goal of treatment is to improve function as long as possible and to emotionally support the patient and the family. Riluzole is used to slow the progression of the disease, and it can prolong life 3 to 4 months. Now we're going to switch over and talk about a few different cranial nerve disorders. First, we're going to talk about trigeminal neuralgia, which is an irritation of the trigeminal nerve, which is your 5th cranial nerve. It affects the sensory portion of the nerve. Etiology is irritation or chronic compression. The trigeminal nerve affects the forehead, nose, cheek, gums, and jaw. The sign and symptom is intense pain on one side of the face. May have frequent blinking and tearing of the affected eye. It is triggered by touching, talking, or other stimulations. They are described, the pain, as a sudden jabbing, burning, or knife-like. It begins and ends suddenly. Attacks can occur in clusters up to hundreds, or can only occur a few times a year. Sleep usually relieves the pain, so these people may try to sleep a lot. They may avoid talking, face washing, teeth brushing, shaving, and eating just to prevent the pain. The diagnosis is going to be based on their history and physical. A CT scan or an MRI can rule out other problems. Some different therapeutic interventions would be anticonvulsants, which reduce the transmission of painful nerve impulses. Nerve blocks can block the nerve and can give 8 to 16 months of relief. And a surgery there could be a permanent loss of sensation if the mandibular branch is severed. Eating becomes a problem. Biting tongue, food gets caught in the mouth. Jaw deviates to an operative site. After surgery, the patient may have numbness on the side of the face. They may need to wear glasses to protect the eye. An eye patch at night is used to protect the eye, and artificial tears to prevent corneal damage. Next, we're going to talk about Bell's palsy. This is the inflammation and edema of the facial nerve, which is the 7th cranial nerve, which has a loss of motor control. This is usually unilateral, and a contracture of the facial muscles can happen if recovery is slow. This is usually one-sided facial with pain, weakness, speech difficulty, drooling, tearing of the eye, and inability to blink. Like I said, it's usually on one side of the face. May be sudden or progressive over 2 to 5 days. It may begin with pain behind the ear. They can also have a dry eye or tingling of the lips. Sense of taste is lost over the anterior 2/3 of the tongue. History and physical, it helps with the diagnosis with an observation of the patient. The main thing we're doing here is we want to rule out a stroke with Bell's palsy. Symptoms of multiple sclerosis are caused by damage to which structure? This would be 4, number 4, the myelin sheath. The patient with which disorder would benefit from avoiding cold, windy weather? This would be number 3. Which nursing intervention is most important for a patient with myasthenia gravis? This would be number 1,